I was given the charge in the next few minutes to talk a little bit about the office examination of the hand and wrist, particularly in the child and adolescent. I think all of us strive to be more efficient in our daily practices. We want to do the best we can with the least amount of wasted effort or time, taking advantage of the skill and knowledge we have, and I hope we can share with you some helpful tools and techniques. So again, my objectives are to talk about some elements of the efficient exam that I hope will be both quick and high yield. Hopefully we'll provide you with some really practical content, and as with anything that we do, we want to put these in some degrees of clinical context to help you. We'll talk a little bit about anatomy and physical examination in the next few minutes. I'll highlight some brief clinical conditions, and that'll certainly be fleshed out further in the hands-on setting. Dr. Villerman will talk a little bit about radiographic imaging, what to get and when to get them, and Peter will talk at the end about some simple maneuvers in the office. So orthopedics, as we all know, is pretty simple. Orthopedic injuries hurt, and that provides us, as rather unsophisticated sleuths, there's a lot of clues on where to go. And anatomy is really everything, and so some of this is going to be a little bit of a review at a fundamental level about the anatomy of the hand and wrist. I think all of us acknowledge we have to consider both intrinsic and extrinsic causes of pain and put everything again into the same context, whether that context is a traumatic injury, a sports-related event, overuse, etc. I think all of you hopefully have reviewed some of the videos that we had posted some years ago, and I would call that out as a helpful resource going forward as well. So the challenges with the hand, particularly in the child or younger child, is that, first of all, they hardly stay still. There is the presence of the growth plates, which is something we all are aware of, but should remind ourselves in the evaluation of a skeletally immature patient. Everything's real small, oftentimes surrounded by pudgy fat and subcutaneous tissues, which can make it challenging. And kids, in addition to being a bit squirmy in our offices, certainly require a little bit more restrictive immobilization, either in a temporizing or definitive fashion. So just a brief skeletal review. I'm hopeful that this projects very well. I'll just remind everyone about the location of the growth plates in the hands and in the bones of the hands. These are common sites of injury, common sites of fracture. We should know where these are. So in the phalanges, in the fingers, the growth plates are proximal, or at the base. This is in contrast to the metacarpals of the hand, those bones that form the bridge of the hand, in which the physes are distal. And of course, there's an exception to every rule, and so the exception in this case is that the thumb metacarpal has its growth plate proximally. And so those are quite simplistically and anatomically are the location of the growth plates. In addition to the skeletal structures and our awareness of the growth plates, it's really important for us to go through some of the tendons that help move the hands and make our hands such elegant machines. I'll remind everyone again that there are 2 flexor tendons to each finger. So the flexor digitorum profundus will flex the distal interphalangeal joint, and there's a separate tendon that will typically flex the proximal interphalangeal joint. And that's really important because in our physical examination, we should be able to isolate each one of those flexor tendons separately. Grossly looking at a finger and seeing it flex does not necessarily rule out a subtle flexor tendon injury, and we will have an opportunity to practice some of these physical examination maneuvers later. Just as there are 2 flexors that flex the fingers palmarly, there's also a very elaborate mechanism that helps us extend our fingers. And this line diagram is quite complicated, but I'll try to make it simple. As the extensor tendon comes down over the hand into the fingers, there are parts of it that go to each individual joint. And so as the extensor tendon comes down, there are some expansions that help us extend the metacarpal phalangeal joint. There's another expansion that helps us extend the proximal interphalangeal joint. And indeed, there's a last terminal extension that helps us extend the very tip or distal interphalangeal joint. And so there are separate components to the extensor mechanism. Certainly there are contributions among other muscles along the way. We can talk about that later if we wish to. But again, the principle is the same. Having someone grossly look like they're extending their fingers does not necessarily rule out an extensor mechanism injury. The onus on us in these situations to examine each joint individually to ascertain we've got it all. So this is just a picture of my finger. I can briefly show you that I can extend my digits, but if you look carefully at my ring finger, as I was a bad adolescent patient, I can't extend the very tip. So while much of my extensor tendon to my ring finger is intact, I can't extend the tip, and this is a classic finding, as we all know, of a mallet finger, something we'll talk about later. Thankfully, arterial or vascular injuries to the hand are quite rare, in part due to the very robust and redundant vascular supply. I'm just going to offer you one anatomic clue that can be helpful in your practices. If you took your hand and looked at it in this fashion with the palm pointing towards the ceiling, we understand that each of the fingers on either side have blood vessels and nerves that supply arterial flow as well as innervation. It's important to understand that the nerves are more palmar than the arteries. Why is this helpful? It's not an uncommon situation where someone might come in after a laceration to the palmar aspect of the finger, and either in your office or the families will recount that they saw what looked like arterial bleeding. Well, if you understand the relationship that it goes from skin to nerve to artery, the only way that bagel knife, the only way that jackknife got the artery is if it went through the nerve. And so just based on that understanding of anatomy, you can oftentimes derive a lot of information and understand that's probably a nerve injury that should be referred along in a timely fashion. Nerve function can be a little bit challenging, particularly in the young child. I'll just remind you again about the innervation of both the sensation and muscles of the hand. So the median nerve, as we all know, innervates the sensation to the radial 3 digits. And the ulnar nerve is predominantly the small finger and the ulnar half of the ring finger. So the median nerve is 3.5 on this side, ulnar nerve is 2.5 on that side. The median nerve helps us with a lot of flexion of the radial side as well as most of the small muscles of the thumb. The ulnar nerve predominantly innervates the small intrinsic muscles of the hand. So if I was going to do a very cursory but efficient exam of the median nerve, you could test for feeling in the thumb and the index finger. You could test for flexion of the thumb as well as opposition of the thumb. So too on the ulnar side, a brief test of sensation on the small finger will give you ulnar nerve function, and asking the child to cross their fingers or open and close their fingers in this fashion would provide a lot of information about the function of intrinsic muscles. The radial nerve provides sensation predominantly on the dorsum of the hand, and it's the radial nerve that helps with extension. So literally by having someone do this, and have them extend their fingers, and then feel in those 3 nerve distributions, very cursory but very efficient examination of neurologic function. There are many other things that can be done. So there's threshold testing. We can look for 2-point discrimination. We can talk about that in the breakouts. And sometimes it's just hard to know. And so I just offer you this pearl. We know that nerves innervate skin, and those afferent fibers will tell the brain that something's happening. Anyone who's been in a hot tub for too long knows that if you keep your hands in the water for too long, the skin gets wrinkly. That's a nerve innervated phenomenon. And so sometimes, particularly in toddlers and babies, if there's a concern about a nerve injury, you can soak them in warm water for 10 minutes in your office, see the next patient come back. And the absence of wrinkling in the skin can be a clue that the nerves in that affected area are not working, the so-called warm water immersion test. We want to derive a lot of information on history, and if there's one examination tool that I would have you leave with today, if you only left with one thing, I would remind you about the tenodesis effect. So we know, and if you take your own hand, we know that if you drop your wrist down, the fingers naturally extend. And if you passively extend the wrist, the fingers will curl up normally, and they all are relatively parallel and aligned, pointing to the ulnar base of the hand. So if I take my hand and I extend my wrist, the fingers curl down, and all my fingers are parallel. If you had a laceration and one of the fingers didn't curl down with the other, you'd be concerned, right, that there was an abnormality in the tendon or perhaps a cut tendon. And so too, if you had a fracture and the bones were not crooked but twisted, you might see something like in this child where with passive wrist extension, you can see that index finger is crossing over and not sitting in its normal parallel alignment. So this is the so-called tenodesis maneuver, very helpful clinical examination tool and very helpful in young where you don't actually have to touch the affected or injured part. You can simply just move the wrist proximal to the zone of injury. So the efficient exam would be simple inspection. I think we can use this tenodesis principle. Orthopedic injuries hurts. We can press on the bony structures, being mindful of where the growth plates are. And we talked a bit about flexor tendon function and nerve testing. Just a final couple comments about the wrist. Wrists are complex, and they're complex for lots of reasons. The bony anatomy is quite complex. If you think about the articulation between the forearm and the hand, there are a host of soft tissue structures and ligaments and supporting elements in the wrist that are confusing for all. And then quite candidly, sometimes the patients that have wrist troubles that we see can be very complex. But the conditions that we oftentimes encounter are pretty common. And with the knowledge, again, of anatomy and some efficient techniques, I think we can understand and get the vast majority of these troubles. In a similar fashion, an efficient examination of the wrist begins with simple inspection. We can check range of motion. And then I'll just highlight a couple specific maneuvers that are helpful for common conditions. So inspection is really important, particularly in the wrist. I think all of us have seen patients with ganglia or masses and things of that sort. This is a small vascular tumor that's a little bit bluish and discolored at the base of the palm. In settings of trauma, we can look for sites of ecchymosis or swelling. We can look for wounds or lacerations. Again, you can see a lot just by looking. Range of motion of the wrist can be pretty quick and efficiently performed, so we can test simple extension of the wrists and flexion of the wrists. And we always have the contralateral side for comparison. That's very helpful. We can look for supination and pronation, so we can look for rotation, and sometimes even simply doing that will highlight some troubles. This is just a silly video of a patient. If you watch, you can see some clicking occurring as one of the extensor tendons subluxes over the ulna. I don't know if that shows well. Orthopedic injuries hurt, so careful palpation of all the bony structures, whether it's in the radius and the ulna, certain carpal bones in the wrist that we'll talk about later can be helped, as well as the tendons and ligamentous structures. So we can look for tendon tenderness in patients who have sports or overuse-related injuries, and we'll talk more in the breakouts about specific signs that might highlight ligament or cartilage injuries. One last thing I'll leave with perhaps is just to remind you about a very common skeletal injury that is oftentimes missed initially. Scaphoid fractures occur with great frequency in children. As you recall, the scaphoid is the most commonly injured carpal bone in the wrist and lives towards the base of the thumb. The areas that you'll elicit tenderness in these injuries include the so-called anatomic snuff box, which is highlighted here in this diagram and we'll go through in the breakout sessions. Remember, too, that the other side of the scaphoid is also palpable. So on the palmar side, we'll talk about this in the breakouts, you can feel the other end of the scaphoid. So pressing on it here, pressing on it there, squeezing it in between, getting that scaphoid all around can help us diagnose sometimes what can be very subtle injuries. And not surprisingly, the more maneuvers we use, the better we can become as physical examiners and diagnosticians. I'm not going to go into much in the way of joint stability, but we'll talk in the breakout groups a little bit of how to assess laxity and how to look at ligamentous stability in the wrist, particularly as it relates to the distal radial ulnar joint and the carpal bones. So I realize that was a little bit of a brief review. I'm hopeful that supplemented some of the pre-course materials, and I look forward to the breakout sessions. Thank you.